Hello, everyone. My name is Yuexing. I'm super excited to share with you our CHI 2024 paper, Advancing Patient-Centered Shared Decision-Making with AI Systems for Older Adult Cancer Patients. This paper is partially sponsored by Cornell University. For the keywords of this paper, we have clinical shared decision-making, artificial intelligence, also having like machine learning models and large language models, and therapeutic communication. Shared decision-making in a clinical setting is pretty urgent and tight. Since the clinical setting is a highly sensitive area, we're trying to understand how patient could involve in this kind of shared decision-making process and then become part of it. It could partially improve their therapeutic communications, also the trust in the patient-clinician relationship, as well as the health outcomes. So in the first part, we have a preliminary study, which we interviewed 7 older adult patients and 5 clinicians. And we gathered this kind of preliminary 10 important factors selection diagram with 12 participants. So as you can see, survival rates in 5 years, potential risk are the 2 most important factors for shared decision-making. And we also have other factors, including alternative treatment options, average patient age for the treatment clinical trials, the treatment duration, treatment distance, nursing service, as well as some costs or fees. And then we're thinking about designing this shared decision-making AI system after collecting these 10 important factors. We introduced the double diamond method for our shared decision-making process. So as you can see, our conventional shared decision-making is most like a single diamond framework. So the clinicians were trying to discover the disease, define the health outcomes, and it almost goes to the end of the final clinical decision. However, in our project, we're trying to involve the patients in this short time. After clinicians finishing up the discovery and define the health outcomes, the patients are encouraged to involve, to develop the patient outcome interactions, and also deliver the clinical shared decision-making results, following the guidelines and guidance from the clinicians. And then it reach out to the final clinical decision. Follow this kind of the framework, we designed our first iteration of the prototype, of the shared decision-making prototype. As you can see, in this one-page interface, we divide it into 3 stages. We have the patient personal health information, we have the AI predictions for the 4 treatments, and also a no treatment plan just for a benchmark. And our third stage is about the treatment detailed explanations. So it's more like a flipping card. On the front end, we have the 5 vectors compared very intuitively across all 4 treatments. And on the back, if the end users, like patients without clinical background, would like to know more information about the specific treatment, we encourage them to read about the detailed explanations. However, this first iteration interface got a lot of the pushback from our participants. And we're recruiting actually 17 other older adult cancer patients and 6 clinicians related to cancer field to understand how ISDM is being built. So ISDM, the stepwise process is look like this. We develop the same 3 stages. However, we divide them into 6 steps. Our usability study workflow, starting from welcoming and consent form, asking for a little preliminary interviews like demographic, cancer type questions, pre-study shared decision-making, and AI attitude interview. And we provide instructions for how to interact with the ISDM system. And then here's the 20 to 30 minutes interactions with the ISDM system. And then we ask for the feedback for their interactions with the ISDM. So the first stage is about patient assessment. We incorporate our preliminary study, the 10 important factors here, and we encourage our end users to select the factors that they care about. And the second step is powered by large language models. We got the EHR data. This John Doe is a hypothetical prostate cancer case, and we're trying to develop this kind of the full description and summary. These are all accessible layman language based on the EHR data. The second stage is about risk evaluation with AI. So since survival rates and side effects are the most important factors from our preliminary studies finding, we designed these 2 important steps. So we compare the 3 treatment options and the no treatment as a baseline, as a benchmark. And then we can change the prediction length from 3 months, 6 months, 9 months to 5 years. For side effects, we also present the visualizations for the 2 important side effects related to prostate cancer. And the last stage is about other factors. So the step 5 other factors are chosen based on step 1's, the end user's feedback. And the last step, which is the most important step, is about finalizing the clinical decisions. We're trying to encourage the end users to reevaluate and re-review the side effects and the predicted survivals, and trying to ask them to finalize their choice. Sometimes they have to make a trade-off because it's not necessarily the same as the best side effects treatment will be the same as the predicted survival treatment. So for analytes, our usability testing, we have 3 basic coding labels: negative cues, positive cues, and neutral cues. And these sample labels are manually labeled by our coders, following the VVVA framework, which are visual, verbal, and video. So as you can see, the sample labels not only contains the verbal cues, but also the gesture cues and also the visual cues, since we do video recording for the whole usability sessions. So here's the sample heat map for evaluating the last step of our ISDN prototype. As you can see, red indicates for negative, green indicates for positive, yellow indicates for neutral verbal cues. So it's pretty clear to see that how these users react to a specific feature of the prototype, and then we are trying to understand how their demands, needs, and satisfactions or unsatisfactions. Here's the Q label analysis across steps. It's pretty obvious to see that the last step has most kind of the reactions, most of the neutral labels and positive labels, and also negative labels are in the last step. So what are our paper contributes to the HCI research on AI in healthcare? It can divide into 4 parts. The first one is it scale up the explanations and communications. Powering biological models or machine learning models, we provide more understandings like layman language to the clinical jargons. And the second one are the educational and informational accessible resources. And the third one is the personalized predictions by AI, and also to promote the end users, especially patients' acceptance and confidence in the clinical settings. This paper is co-authored with Zeyu, Riter, and Dr. Saleh Kalantari. Thank you so much for listening.